Welcome to another lecture by MedicoMedics Pharmacology Corticosteroids. We will begin our lecture with a general introduction of corticosteroids. We will discuss classifications, mechanism of actions, and pharmacokinetics. We will then continue discussing clinical uses, adverse effects, contraindications, drug interactions, and look at a few case examples, and finally end with a summary. Now, corticosteroids are synthetic analogs of glucocorticoids and mineralocorticoids. These are hormones produced by the adrenal cortex. Now, we always divide them into the separate groups of glucocorticoids and mineralocorticoids. So the gluco one reduce inflammation and modulate immune responses. The purpose of the mineralocorticoids is to regulate sodium and water balance. So it's quite distinct differences in what they do. And these are used, the glucocorticoids or the corticosteroids, to treat a wide range of conditions, including autoimmune diseases, asthma, allergies, and adrenal insufficiency, for example. So, again, corticosteroids are medications that mimic hormones produced by the adrenal glands, or adrenal cortex, to be more specific. And they're helping us to reduce inflammation and regulate immune responses. Now, normally, your body uses these hormones to manage stress, control inflammation, maintaining balance in processes like fluid retention, for example, or metabolism. Now, what corticosteroids do is they amplify these effects, making them essential for treating these different types of conditions, as mentioned here. Now, let's dive a little bit into the normal physiology and the structures involved. Now, let's start with the normal physiology of corticosteroids, focusing on the endogenous hormones produced by the adrenal cortex. So, the adrenal cortex synthesizes two key types of corticosteroids. First, we have the glucocorticoid, cortisol. And cortisol plays a critical role or a crucial role in, for example, regulating glucose metabolism, mainly during fasting or stress, further to reduce inflammation or suppressing inflammation, and of course, modulating immune responses in order to prevent overactivation. You can also, in parallel, as we are going through this, see here an illustration of our adrenal glands, right? You can see it here, and you can see the division of the cortex and the medulla. Further, you can see a more detailed image here of the microscopic layers of the adrenal cortex. And it is divided into the zona glomerulosa, fasciculata, and reticularis. And here you can see cortisol. So it is produced in the zona fasciculata. So that's the first one. Now let's look at the second one, where we have the mineralocorticoid aldosterone. And aldosterone here is primarily responsible for maintaining sodium and water balance and regulating blood pressure. And it regulates blood pressure by acting on the distal renal tubules in order to promote sodium reabsorption and the excretion of potassium. Now, these hormones discussed here, right, they are part of a very finely tuned system called the hypothalamic pituitary adrenal axis, or HPA axis. So in response to, for example, stress, the hypothalamus, right, secretes something called CRH, which is corticotropin releasing hormone. This in turn then stimulates the pituitary gland to release ACTH, which is adrenocorticotropic hormone. And this then finally triggers or signals the adrenal cortex to produce and release cortisol. And what is then the role of this cortisol here? Well, the role would be in this axis, right? In this context, the role of cortisol is to help the body maintain homeostasis during stress. So it's, again, its purpose is to help regulate the metabolism, support cardiovascular function, control inflammation, by, for example, reducing it, modulating the immune system, etc. So now we've talked about endogenous corticosteroids, right? Now, when we talk about exogenous, right, not endogenous, but exogenous corticosteroids. So first of all, in medicine, endogenous corticosteroids means that they are naturally produced by the adrenal glands, while exogenous corticosteroids are synthetic drugs administered to mimic or supplement those hormones we have. So now when we talk about exogenous corticosteroids, meaning those given as medication, like, for example, prednisone, dexamethasone, or hydrocortisone, they mimic the effect of cortisol and aldosterone. However, and this is very important, however, even though they mimic the effects of cortisol and aldosterone, they bypass the HPA axis. So this axis here is not involved, right? Because what did we say normally? We have stress. This stress signals our hypothalamus to start releasing CRH, which triggers ACTH release, which triggers adrenal cortex production or cortisol production, right? We don't have that here. We are giving the patient medication to mimic this. Now, a little clinical pearl here. A chronic use of exogenous corticosteroids, meaning from medication, can actually lead to suppression of this HPA axis because the body detects sufficient glucocorticoid levels and then reduces endogenous cortisol production. This is why tapering off steroids is so important. It's to allow the adrenal glands time to resume normal function and to prevent adrenal insufficiency. So overuse of this medication suppresses the HPA axis, right? Your body already senses that there are high levels of glucocorticoids available, so the HPA axis doesn't need to activate. It becomes suppressed. Now, if you suddenly stop taking these drugs, let's say, so you don't have this constant continued influx of these glucocorticoids, you should have a functioning HPA system, but it's now suppressed. So in the space where you actually don't have a production anymore from your own system, you also don't have the medical use anymore because you stopped. So there will be a gap where it will be insufficient amount. And this is what we simply essentially call the state of adrenal insufficiency. That's why getting off these drugs needs to be controlled and over time in order to let our HPA axis or our normal physiological system regain its normal function. Now, when we discuss the normal physiology of our adrenal glands in general, or of glucocorticoids, we have to turn our attention not only to cortisol, meaning our glucocorticoids, but also, of course, the mineralocorticoids like aldosterone. And we mentioned that aldosterone plays a central role in controlling sodium and water balance. And the system, or a key hormonal pathway that regulates blood pressure, fluid balance, or electrolyte homeostasis, is what is illustrated here: the renin-angiotensin-aldosterone system. And it does it primarily through the action of the mineralocorticoid aldosterone. And as we mentioned, it is endogenously produced in the adrenal cortex. So the process here begins when the kidneys sense a reduced perfusion, right? Our blood travels through our kidneys for filtration. If your kidneys, illustrated here, for example, with the adrenal glands sitting on top, if your kidney or kidneys sense a reduced perfusion due to, for example, low blood pressure or low blood volume or low sodium levels, for example, this will lead to the release of renin, right? The first name here in the RAS system. And this renin here, a response to decreased blood pressure or a decreased perfusion to our kidneys, comes from or is released from the juxtaglomerular cells. That's a mouthful. And this renin then converts angiotensinogen, seen here in the illustration, which is primarily produced in the liver. So you can see here the kidney here, the liver here. So the liver releases angiotensinogen. The kidney, in response to low perfusion, releases renin. Now, renin converts the angiotensinogen into angiotensin 1. And angiotensin 1 is then converted into angiotensin 2 with the aid of ACE enzyme, which stands for angiotensin converting enzyme. And this is primarily from the lungs or in the lungs. Now, angiotensin 2 has multiple effects. To name a few, it constricts the vascular smooth muscle, so we get vasoconstriction. It stimulates the adrenal cortex to release aldosterone, right? Here is the adrenal cortex. It releases aldosterone. And since it is the topic here, what does aldosterone do? Well, it acts on the distal renal tubules, right? Because you have your filtration happening in the glomerulus, and then we have our descending loop, we have our ascending loop, we have our distal convoluted tubule, etc., etc. Without diving into more details here. Now, this is telling us that aldosterone acts on the distal convoluted tubule or distal renal tubules. And here in this area, it is promoting sodium reabsorption and potassium excretion. And as sodium is absorbed back, water will, of course, follow it. So if we have water following the sodium back, if it is being reabsorbed, it means we have water retention increasing. And what does that lead to? Well, an increase in blood volume and pressure. So it has essentially counteracted. It counteracts the initial signal, which is we have low blood pressure due to low perfusion, for example, due to low blood volume. So the response here is to increase blood volume and to therefore then increase blood pressure. Now, let's put this into the context of corticosteroid pharmacology, right? So this image here, the image of the RAS system, emphasizes the role of mineralocorticoids like aldosterone, right, in maintaining homeostasis. We have low blood pressure, we want to increase it back to balance. So homeostasis. Now, exogenous corticosteroids, like fludrocortisone, for example, can mimic aldosterone's effects and are used therapeutically, for example, in conditions like adrenal insufficiency, also known as or called Addison's disease. Now, unlike glucocorticoids that mainly suppress inflammation and immune activity, mineralocorticoids directly regulate electrolyte balance and blood pressure. So it links the RAS system to a broader endocrine and cardiovascular function. So understanding this system helps explain why some corticosteroids have both glucocorticoid and mineralocorticoid activity, and why their use must be tailored to the patient's physiological needs. Now let's do some brief classification of these corticosteroids. So we have the glucocorticoids, examples, prednisone, dexamethasone. Its primary action include that it's anti-inflammatory and immunosuppressive. So for example, we're talking about cortisol here. What about the mineralocorticoids like aldosterone? Examples of exogenous ones is fludrocortisone, and the primary action, water balance and sodium retention. Then we have some mixed ones like hydrocortisone. It is both anti-inflammatory effects and sodium retention. Now let us go through the mechanism of action of corticosteroids. As we've mentioned, we use corticosteroids mainly for their potent anti-inflammatory and immunosuppressive properties. So let us look at how it affects the different cells in our immune system. For example, we have our macrophages, our natural killer cells, our dendritic cells, and in our adaptive immune system, we also have the T cell, we have the B cell, the helper cells, etc. So, what is the effect of corticosteroids on dendritic cells, for example? Well, starting with dendritic cells, the corticosteroids reduce their proliferation, for example, and their ability to produce key pro-inflammatory cytokines, like tumor necrosis factor alpha, like interleukin 12, for example. And these are pro-inflammatory cytokines amplifying the immune response, right? Or the inflammatory response. So the effect would be a reduction here. And that goes sort of hand in hand with an anti-inflammatory effect. What about the effect of corticosteroids on macrophages? Well, in macrophages, corticosteroids increase apoptosis. And apoptosis means programmed cell death. So it increases, essentially, the destruction of macrophages. Furthermore, it reduces the production of interleukin 1 beta. This is another pro-inflammatory cytokine. So this will reduce the effect of corticosteroids on macrophages, will reduce macrophage-mediated tissue damage and systemic inflammation. So again, it's aligned with decreasing or suppressing inflammation. What about on the B cell? So for example, corticosteroids induce apoptosis. Like with macrophages, here it induces again apoptosis. Furthermore, it reduces immunoglobulin G production, and this weakens the humoral immune response. So, in short, then, corticosteroids sort of orchestrate a broad suppression of the immune system. They reduce the activation and proliferation of dendritic cells, for example. They induce apoptosis and suppress cytokine release in, for example, macrophages, in T cells, in B cells. And you can see it here as well, right? On our T cells, we have the increase of apoptosis. And that's not a good word here because it means programmed cell death, meaning the destruction essentially, or reduction all in all of these different immune cells. So the net effect, right? The net effect is what? Well, reduced inflammation. We will have less immune cell recruitment and a shift away from pro-inflammatory signaling. So in conclusion, we will have a suppressed immune system. We will have a decreased inflammatory response. And I would strongly recommend that you get familiar on this very specific level where the hormone or drugs discussed here, the use of corticosteroids, and the direct effect it has on very specific cells in our body. And if you have studied immunology, or you will, perhaps, you will be familiar with the crucial importance of all these different cells, both for our innate and adaptive immune system. Now let's take a look at pharmacokinetics. So the table here outlines the key pharmacokinetic properties of commonly used corticosteroids, and this helps us guide clinical decision making. So beginning with prednisone. Now prednisone is a prodrug that undergoes hepatic conversion into prednisolone, which is its active form. And this means that liver function is very important for its efficacy. Now, it is rapidly absorbed orally and excreted renally, making it a reliable choice for treating, for example, systemic inflammation. Then we have dexamethasone. It is a long-acting and highly potent glucocorticoid, also well absorbed orally and metabolized in the liver and excreted in the kidneys. Now, its long duration makes it a very suitable candidate for conditions that require sustained anti-inflammatory effects. Then we have hydrocortisone, which is the synthetic form of cortisol. It has a moderate oral absorption, often used in adrenal insufficiency, mimicking the natural hormones' diurnal rhythm. Then we have fludrocortisone, and due to its very strong mineralocorticoid activity, it's particularly useful in conditions like Addison's disease, where aldosterone replacement is needed. But all in all, you can see two recurring patterns here. So all of these agents mentioned here undergo hepatic metabolism and renal excretion. And this should then tell you that liver and kidney function should always be considered during prescription. Now, different corticosteroids are preferred, of course, depending on the clinical condition and the desired route or duration of action. So in autoimmune diseases, for example, like lupus or rheumatoid arthritis, prednisone is commonly used due to its strong systemic anti-inflammatory effects. What about in asthma or COPD? Here we have inhaled budesonide, and it is preferred for long-term control, while oral prednisone is used during acute exacerbations. Now, for adrenal insufficiency, for example, such as Addison's disease, hydrocortisone replaces cortisol, and fludrocortisone provides the necessary mineral corticoid activity that is lost. So we will have the sort of replacement of both. In cases of severe allergic reactions or anaphylaxis, dexamethasone is often used as an adjunct to epinephrine due to its long-acting anti-inflammatory properties. Dexamethasone is also effective in reducing cerebral edema, for example, particularly in patients with brain tumors or head trauma. Furthermore, in sepsis or septic shock, hydrocortisone may be administered as adjunct therapy in patients who remain hypotensive despite fluids and vasopressors. Now, what are then some adverse effects? Well, corticosteroids can cause a range of adverse effects, right, across multiple body systems. In the endocrine system, prolonged use can suppress, as we mentioned before, the hypothalamic pituitary adrenal axis, the HPA axis, leading to adrenal suppression, meaning a condition where the body's own cortisol production is reduced. So to avoid adrenal crisis, doses must be tapered gradually. Metabolically, corticosteroids promote gluconeogenesis and increase appetite, resulting in hyperglycemia and weight gain, for example. And this can complicate diabetes and metabolic syndrome. In the musculoskeletal system, long-term use of corticosteroids decrease calcium absorption and impairs bone formation. So it can contribute to osteoporosis and muscle weakness, for example. Immunologically, corticosteroids suppress immune system function, right? Making patients far more susceptible to infections, especially opportunistic ones. Dermatologically, chronic use, especially topical use, like a cream, can cause skin thinning, can cause easy bruising or delayed wound healing. And this is due to its impaired collagen synthesis and tissue repair. So there are a lot of very systemic and even local potential consequences with the use of corticosteroids or glucocorticoids. And this needs to be taken into account when prescribing these different medications. Now then, what are some contraindications for corticosteroids? Well, they are contraindicated or used with caution in a lot of different conditions, and this is due to its systemic effects. In, for example, uncontrolled infections, they will suppress the immune system response, potentially, therefore, allowing the infection to actually worsen. In patients with active peptic ulcers, corticosteroids may increase gastric acid secretion and delayed healing, this would raise the risk of complications. In uncontrolled diabetes, for example, they can worsen the hyperglycemia by promoting gluconeogenesis and insulin resistance. And finally, osteoporosis. So corticosteroids accelerate bone loss, leading to an increase of fractures, for example. Now, when prescribing corticosteroids, it is essential to consider potential drug interactions, right? As they can significantly alter both efficacy and safety. Now, all corticosteroids, such as prednisone, dexamethasone, hydrocortisone, for example, when they're used concurrently with NSAIDs, so non-steroidal anti-inflammatory drugs, can increase the risk of gastric ulcers and also therefore of bleeding, right? So this addictive effect occurs because both of these drug classes impair protective mechanisms in the gastric mucosa. Now, prednisone, which is indeed a commonly used systemic corticosteroid, can interact with warfarin, which is an anticoagulant. Now, this interaction may alter INR levels, leading to either subtherapeutic or supratherapeutic anticoagulation. So as a result of this interaction or potential interaction, there has to be a close monitoring of INR. And so that is advised when these two drugs are used together. Then we have dexamethasone, which is indeed a very potent glucocorticoid. And it is metabolized via the cytochrome P450, or more specifically 3A4. So the CYP3A4 pathway. So if it's co-administered with CYP3A4 inducers, like for example, rifampin, which is a drug used when treating, for example, tuberculosis, it can accelerate its metabolism, leading to a reduction of the therapeutic effect of dexamethasone. So in such cases, higher corticosteroid doses or alternative agents may be necessary to still maintain efficacy. Now let's take a look at a few case examples. So let's begin with a classic use of glucocorticoids in autoimmune disease. So here we have a 28-year-old woman presenting with fatigue, arthralgia, and what seems to be a malar rash. Lab test confirms that it is systemic lupus erythematosus. So for this patient, we initiate prednisone, which is a commonly used oral glucocorticoid, right? We do it to reduce systemic inflammation and to modulate immune activity. Now, this connects directly to our lecture on glucocorticoid mechanisms, right? Because prednisone binds to intracellular glucocorticoid receptors and downregulates the pro-inflammatory cytokines, like, for example, tumor necrosis factor alpha, interleukin 1, and suppresses immune cell migration. So in clinical practice, we monitor carefully for adverse effects such as hyperglycemia and osteoporosis, especially with the chronic use of these medications. Let's take a look at another one. So adrenal insufficiency, or Addison's disease, right? Here we have a primary endocrine disorder, adrenal insufficiency. 45-year-old man presents to us with chronic fatigue, low blood pressure, and skin hyperpigmentation. If you've studied Addison's disease, this sort of screams that it's Addison's. And the lab results confirm that we're dealing with Addison's, which is indeed a condition that both aldosterone and cortisol are deficient. So here we treat with hydrocortisone. And we do that to replace both cortisol and we use fludrocortisone to provide mineralocorticoid support, right? And again, this also ties directly to the physiology we discussed before. Hydrocortisone mimics endogenous cortisol's glucocorticoid. The effects of the endogenous cortisol's effects, right? While fludrocortisone binds mineralocorticoid receptors to regulate sodium and water balance. So this shows that, or this case illustrates the critical difference between glucocorticoids and mineralocorticoids and why both are essential in adrenal replacement therapy. What about in asthma exacerbation? So let's look at corticosteroids and how we use it in respiratory medicine, right? So we have a 22-year-old woman presenting with classic signs of asthma exacerbations like wheezing, dyspnea, cough. Now, in the acute phase, we use a short course of oral prednisone. And we do that to quickly reduce airway inflammation and immune activation. However, once we've stabilized the patient, we transition her to inhaled budesonide for long-term control. So this case sort of emphasizes that route, right? Route matters. Systemic steroids, we use them for flare control, inhaled for chronic management here. It demonstrates how we apply our understanding of pharmacokinetics and corticosteroid receptor activity in our clinical decision making. So this is a good example of why the way we give the medication, the route, why it matters. We can also take one last example here of an emergency indication, for example, cerebral edema. So we have a 65-year-old woman. She's presenting with headache, nausea, signs of intracranial pressure elevation. Imaging reveals that she has a brain tumor with surrounding edema. So what do? We administer dexamethasone, which is a potent, long-acting glucocorticoid with minimal mineralocorticoid activity. So why dexamethasone? Because it's a strong anti-inflammatory drug. It has strong anti-inflammatory effects that will help reduce vascular permeability and cerebral swelling, relieving the pressure on brain structures. So in summary then, corticosteroids are powerful drugs that modulate inflammation and immune responses. They are versatile, treating a wide range of conditions, but requires careful use to avoid long-term complications. Of course, monitor for side effects, taper therapy to avoid adrenal suppression, and tailor dosing to the patient's condition. And that's the end of this lecture. If you like this video, please leave a comment, like, and subscribe to help us grow.